Immune checkpoint inhibitors, or ICIs as we call them, have completely changed the game in cancer treatment. I mean, they're a true revolution. But with that kind of power, the power to unleash the body's own immune system, it comes with a pretty unique set of challenges. So today, we're going to dive into one of the most critical but also highly manageable of those challenges: ICI-induced diabetes.
So, how do these drugs actually work their magic? Well, in a nutshell, cancer cells are really sneaky. They put the brakes on our immune system's T cells, basically telling them, hey, don't attack me. They use signals like PD-L1 to do this. What ICIs do is they come in and block those signals. They inhibit checkpoints like CTLA4 and PD-1, and what that does is it effectively cuts the brake lines. It frees up our T cells to finally recognize and go after the tumors. This powerful response, well, that's the incredible promise of immunotherapy.
All right, so here's our game plan. We're going to walk through this topic step by step, starting with the big picture and then really zeroing in on the practical, clinical info you need to know.
Okay, first things first. Let's set the stage and talk about just how common these therapies have become.
I mean, just let that sink in for a second. We're talking about roughly half of all cancer patients in the U.S. being potential candidates for this therapy. This isn't some niche treatment anymore. It is an absolute cornerstone of modern oncology. And you know what that means? It means providers in every specialty, not just oncology, really need to get familiar with their unique side effects.
So if releasing the brakes on the immune system is the promise, then the peril is what can happen when that supercharged immune system veers a little off target. And that brings us to what we call immune-related adverse events, or irAEs.
Right, so the very same mechanism that makes these drugs so incredibly effective against cancer can also, sometimes, trigger inflammation in perfectly healthy organs. And the endocrine system? Well, it turns out to be a particularly common target. Now, why is that? We're still figuring out all the details, but it might be because of shared antigens between tumors and endocrine tissues, or maybe just a high expression of these immune checkpoints on the glands themselves.
This table here gives us a fantastic overview of the most common endocrine side effects. As you can see, thyroid issues are definitely the most frequent, hitting up to 8% of patients. But look down there at the bottom, the pancreas. Now, an incidence of around 1% might seem low, right? But the clinical fallout from this particular side effect is so profound, which is exactly what we're going to focus on next.
So let's pivot. We're now going to zoom in and focus entirely on the pancreas and this rare but incredibly urgent problem of ICI-induced diabetes.
First off, let's be super clear, this is not a common event. The overall incidence is low, affecting just about 1% of patients who are on these therapies.
But, and this is a huge but, when it does happen, it's almost always severe. We're talking approximately 70% of these patients showing up in a life-threatening state of diabetic ketoacidosis, or DKA. It's this stark contrast, low incidence, high severity, that makes it so critical to recognize this early.
So what exactly is going on here? This isn't your typical type 1 or type 2 diabetes. No way. ICI-induced diabetes is a fulminant, aggressive autoimmune process. The immune system launches this sudden, overwhelming attack on the insulin-producing beta cells in the pancreas, and it leads to an absolute, almost overnight loss of insulin.
And get this, the timing is incredibly unpredictable. The median onset is somewhere between 7 and 20 weeks after starting the therapy, but cases have popped up as early as 1 week and as late as a full year after the first dose. This huge window means that as a clinician, you can never really let your guard down.
So given how fast this thing hits, how do we diagnose it? Well, the key is knowing just how different it is from the classic autoimmune diabetes that we're all more familiar with.
You know, this quote from Dr. Melissa Lechner really just nails it. We can't rely on our usual playbooks here. The way it presents, the lab work, the management, it's all unique, and recognizing these differences is absolutely vital.
So let's really break down the key differences. First, look at the onset speed. It is incredibly rapid. We're talking days to weeks, not the more gradual slide you see in classic type 1. Second, C-peptide. That's our marker for how much insulin the body is making. In over 80% of these cases, it's very low or totally absent at diagnosis. That tells you just how fast that beta cell destruction is happening. And finally, check out the autoantibodies. In classic type 1, they're almost always there. Here, it's basically a coin flip. Only about half of patients have them. This means, and this is a really critical takeaway, the absence of autoantibodies does not rule out ICI-induced diabetes.
Okay, so you've made the diagnosis. What do you do next? This is where having a clear, decisive management plan is absolutely essential.
Here are the 4 absolute core principles. Think of them as your non-negotiables. First, these patients have 0 insulin, so you have to start insulin therapy immediately. Second, and we're going to come back to this, do not use glucocorticoids. Third, this isn't necessarily a reason to stop the cancer treatment. Often the ICI therapy can continue. And fourth, get your endocrinology colleagues on the phone early.
Okay, I really want to emphasize this point because it's a major clinical pitfall. For most other immune side effects, our reflex is to reach for high-dose steroids. In this case, that is the absolute wrong move. Glucocorticoids are totally ineffective. They don't do anything to reverse the beta cell damage. And what's worse, they will make the hyperglycemia much worse and can actually push a patient into DKA. And here's another key distinction you have to get. This damage is permanent. Even if the ICI is stopped, the beta cells are not coming back. There's no honeymoon phase of partial recovery like we sometimes see in classic type 1 diabetes. From the moment of diagnosis, these patients will need lifelong insulin therapy.
All right, let's pull all of this together into a simple, actionable checklist you can take right into your practice.
Okay, here's the rundown. First, suspect it. In any patient on an ICI who has hyperglycemia, thirst, or is peeing a lot, this has to be on your radar. To diagnose it, check a glucose, check for ketones, and crucially, order a C-peptide. That low C-peptide is your biggest clue. To treat it, remember insulin is the mainstay, and please do not use glucocorticoids. And remember the key features? The onset is rapid, DKA is common, and this condition is permanent. And finally, collaborate. Get endocrinology involved from the very beginning.
So we've spent this time talking about how to react when this serious side effect happens. But the bigger question, the one for the future, is how do we get ahead of it? How do we move from just reacting to these side effects to actually predicting and maybe even preventing them? The next frontier isn't just about managing the fallout. It's about learning who's at risk and maybe one day figuring out how to stop these powerful therapies from causing this kind of collateral damage in the first place.